By studying this chapter, circulatory responses to exercise. Objectives. By studying this chapter, you should be able to do the following. Provide the overview and design and function of the circulatory system. Describe the cardiac cycle and associated electrical activity recorded via electrocardiogram. Discuss the pattern of redistribution of blood flow during exercise. Outline the circulatory responses to various types of exercise. Identify the factors that regulate local blood flow during exercise. List and discuss the factors responsible for regulation of stroke volume during exercise. Discuss the regulation of cardiac output during exercise. One of the major challenges to homeostasis posed by the exercise is increased muscular demand for oxygen during heavy exercise. This demand may be 15 to 25 times greater than at rest. The primary purpose of cardiorespiratory system is to deliver adequate amounts of oxygen and remove waste from the body tissues. Further, the circulatory system also transports nutrients and aids in temperature regulation. It is important to remember that the respiratory system and the circulatory system function together as a coupled unit. The respiratory system adds oxygen and removes carbon dioxide from the blood, while the circulatory system is responsible for the delivery of oxygenated blood and nutrients to the tissues in accordance to their needs. In simple terms, the cardiorespiratory system works as a unit to maintain oxygen and carbon dioxide homeostasis in the body tissues. A British physician, William Harvey, proposed the first complete theory about how the cardiovascular system works in humans. See a look back in Important People in Science. A look back Important People in Science. William Harvey developed the first complete theory of circulatory system. William Harvey, 1578 to 1657, was born in England and was educated in both King's College and the University of Cambridge. He later studied medicine at the University of Padua in Italy. After completion of his medical studies, he returned to England and became the personal physician of King James I. Dr. Harvey was fascinated by the anatomical studies, and King James I encouraged him to pursue research to improve the practice of medicine. As a researcher, William Harvey made many important discoveries about how the cardiovascular system operates. First, by observing the action of the heart in small animals, Harvey proved that the heart expels blood during each contraction. Further, he also discovered that valves exist in the veins and correctly identified them as restricting the blood flow in one direction. Dr. Harvey's work on the circulatory system was summarized in a book published in 1628 titled An Anatomical Study of the Motion of the Heart and the Blood in Animals. This text explained Harvey's theories on how the heart propelled blood through the circular course throughout the body and was the first published record to accurately describe how the circulatory system works in humans and other animals. To meet the increased oxygen demands of the muscle during exercise, two major adjustments of the blood flow must be made. An increased cardiac output, example, increased amount of blood pumped per minute by the heart, and two, restriction of blood flow from inactive organs to active skeletal muscles. However, while the need of muscles are being met, other tissues such as the brain cannot be denied blood flow. This is accomplished by maintaining blood pressure. The driving force behind blood flow. Although a thorough understanding of the cardiovascular responses to exercise is important for a student of exercise physiology. Therefore, this chapter describes the design and function of the circulatory system and how it responds during exercise. We begin with a brief review of anatomy and function of the heart and blood vessels. Organization of the circulatory system. The human circulatory system is is a composed loop that circulates blood to all body tissues. Hey Google, set an alarm for 11 p.m. The human circulatory system is a closed loop that circulates blood to all body tissues. Circulation of blood requires the action of muscular pump. The heart requires a muscular pump. The heart that creates the pressure head needed to move blood through the system. Blood travels away from the heart in arteries and returns to the heart by the way of veins. The system is considered closed because arteries and veins are continuous with each other through smaller vessels. Arteries branch extensively to form a tree of the smaller vessels. As the vessels become microscopic, they form arterioles, which eventually develop into beds of much smaller vessels called capillaries. Capillaries are the smallest and most numerous blood vessels. All exchanges of oxygen, carbon dioxide, and nutrients between tissues and the circulatory system occur across the capillary beds. Blood passes from capillary beds to venous vessels called venules. As venules move back toward the heart, they increase in size and become veins. Major veins empty directly into the heart. The mixture of venous blood from both the upper and lower body that accumulates in the right side of the heart is termed the mixed venous blood. The venous blood therefore represents an average of venous blood from the entire body. Structure of the heart. The heart is divided into 4 chambers and is often considered to be 2 pumps in one. The right atrium and the right ventricle form the right pump, and the left atrium and the left ventricle combine to make the left pump. See figure 9.1. Aorta. Left pulmonary artery, right pulmonary artery. Right pulmonary veins, superior vena cava, inferior vena cava. Right tricuspid valve, interatrial septum, chordae tendineae, right ventricle, pulmonary, semilunar valve, aorta, left pulmonary veins, pulmonary trunk, left atrium, left bicuspid valve, aortic semilunar valve, left ventricle, papillary muscle, interventricular septum, myocardium, epicardium, pericardial fluid space, pericardium. The right side of the heart is separated from the left side by a muscular wall called the interventricular septum. This septum prevents the mixing of blood from the 2 sides of the heart. Blood movements within the heart is from the atria to the ventricles, and from the ventricles blood is pumped into the arteries. To prevent backward movement of blood, the heart contains 4 one-way valves. The right and left atrioventricular valves connect the atria with the right and left ventricles, respectively. These values are also known as tricuspid valves, right atrioventricular valve, and the bicuspid valve, left atrioventricular valve. Backflow from the arteries into the ventricles is prevented by the pulmonary semilunar right valve and the aortic semilunar left valve. Pulmonary and systemic circuits. As mentioned previously, the heart can be considered two pumps in one. The right side of the heart pumps blood that is partially depleted of its oxygen content and contains elevated carbon dioxide content as a result of a gas exchange in various tissues of the body. This blood is delivered to the right. It's delivered from the right heart into the lungs through the pulmonary circuit. At the lungs, oxygen is loaded into the blood and the carbon dioxide is released. This is oxygenated blood and then travels to the left side of the heart and is pumped to the various tissues of the body via the systemic circuit. Figure 9.2. Systemic circuit. Oxygen poor, oxygen rich. Go into here. Oxygen rich, CO2 poor, blood. Illustration of systemic and pulmonary circulations. As depicted by the color change from blue to red, blood becomes fully oxygenated as it flows through the lungs, and then it loses some oxygen, changes color from red to blue as it flows through the organs and tissues. In summary, the purposes of the cardiovascular system are the following: transfer of O2 to tissues and removal of waste, the transfer of nutrient to tissues, and 3, the regulation of body temperature. The heart is two pumps in one. The right side of the heart pumps blood through the pulmonary circulation, and the left side of the heart delivers blood to the systemic circulation, the heart, myocardium, and cardiac cycle. To better appreciate how the circulatory system adjusts to the stress of exercise, it is important to understand the elementary details of heart muscle structure, as well as the electrical and mechanical activities of the heart. The myocardium. The wall of the heart is composed of 3 layers. The outer layer called the epicardium, a muscular middle layer called the myocardium, and the inner layer as an endocardium. See figure 9.3. Figure 9.3. The heart wall is composed of 3 distinct layers: the epicardium, 2 the myocardium, and 3 the endocardium. Coronary vessels, fibers, pericardium, serous pericardium, pericardial cavity layer, the epicardium, visceral pericardium, characteristic serous membrane including blood capillaries, lymph capillaries, and nerve fibers. Function: serves as a lubricant outer covering. Myocardium, cardiac muscle tissue separated by connective tissues, and including blood capillaries, lymph capillaries, and nerve fibers. Provides muscle contractions that eject blood from the heart chambers. Endocardium, the endothelial tissue and the thick subendothelial layer of the elastic and collagenous fibers. Serves as a protective inner lining of the chambers and the valves. It is the myocardium or heart muscle that is responsible for contracting and forcing blood out of the heart. The myocardium receives its blood supply via the right and left coronary arteries. Coronary arteries, which branch off the aorta and encircle the heart. The coronary veins run alongside of the arteries and drain all the coronary blood into the larger vein called the coronary sinus, which deposits into the right atrium. Maintaining a constant blood supply to the heart via the coronary arteries is critical because even at rest, the heart has a high demand for oxygen and nutrients. When coronary blood flow is disrupted, example blockage of the coronary blood vessel for more than several minutes, permanent damage to the heart occurs. This type of injury results in death of the cardiac muscle and is commonly called a heart attack. commonly called a heart attack or myocardial infarction. The number of heart cells, example muscle fibers, that die from the result determines the severity of the heart attack. That is, mild heart attack may damage only a small portion of the heart, whereas a major heart attack may destroy a large number of the heart cells fibers. A major heart attack greatly diminishes the heart's pumping capacity, therefore minimizing the amount of injury to the heart during a heart attack is critical. Importantly, strong evidence indicates that exercise training can provide cardiac protection during a heart attack. See clinical applications 9.1. Clinical application 9.1. Exercise training protects the heart. It is now well established that regular exercise training is cardioprotective. Indeed, many epidemiological studies have provided evidence that regular exercise can reduce the incidence of heart attacks and that the survival rate of a heart attack victim is greater in active people than in sedentary ones. Recent experiments provide direct evidence that regular endurance exercise training reduces the amount of regular endurance exercise training reduces the amount of cardiac damage that occurs during a heart attack. The protective effect of exercise is illustrated in Figure 9.4. Figure 9.4. Regular endurance exercise protects the heart against cell death during a heart attack. Note that during a myocardial infarction, example heart attack, exercise-trained individuals suffer significantly less cardiac injury compared to untrained individuals. Percentage of cardiac injury during a myocardial infarction. Trained, untrained. Notice that the exercise training can reduce the magnitude of cardiac injury during a heart attack by approximately 60%. This is significant because the number of cardiac cells that are destroyed during a heart attack determines the patient's chances of full functional recovery. Animal experiments indicate that exercise-induced protections against myocardial injury during a heart attack can be achieved quickly. For example, it appears as few as 3 to 5 consecutive days of aerobic exercise. It appears that as few as 3 to 5 consecutive days of aerobic exercise, approximately 60 minutes per day, can provide a significant cardiac protection against a heart attack mediated damage to the heart muscle. How does exercise training alter the heart and provide cardio protection during a heart attack? A definite answer to this question is not available. Nonetheless, evidence suggests that the exercise training induced improvement to the heart's ability to resist permanent injury during a heart attack and is linked to improvements in the heart's antioxidant capacity. Example, the ability to remove free radicals. For more details, see Powers et al. It's suggested readings. Heart muscle differ from skeletal muscle in several ways. First, cardiac muscle fibers are shorter than skeletal muscle fibers and are connected to in a tight series. Further, cardiac fibers are typically branched, whereas skeletal muscle fibers are elongated and do not branch. Also, cardiac muscle contraction is involuntary, whereas skeletal muscle contractions are under voluntary control. Another difference between cardiac fibers and skeletal muscle fibers is that, unlike skeletal muscle fibers, heart fibers are interconnected via intercalated discs. These intercellular connections permit the transmission of electrical impulses from one fiber to another. Intercellular discs allow ions to cross from the cardiac muscle fiber to another. Therefore, when a heart fiber is depolarized, to contract, all the connecting heart fibers will become excited and contract as a unit. This arrangement is called a functional syncytium. Heart muscle cells and the atria are separated from the ventricular muscle cells by a layer of a connective tissue that does not permit the transmission of electrical impulses. Hence, the atria contract separately from the ventricles. One more difference between the heart and skeletal muscle fibers in that human heart fibers are not divided into different fiber types. The ventricular myocardium is considered to be a same muscle containing one primary fiber type that has similarities of type 1 slow fibers found in skeletal muscle. In this regard, heart muscle fibers are highly aerobic and contain large numbers of mitochondria. Note that, however, the cardiac muscle fibers contain how many more mitochondria than note however that cardiac muscle fibers contain many more mitochondria than type 1 muscle fibers, so skeletal muscle fibers. This fact highlights the importance of continuous aerobic metabolism of the heart. The final difference between the cardiac and the skeletal muscle fibers is the ability to recover from following an injury to the muscle fibers. Recall from Chapter 8 that skeletal muscle fibers are surrounded by a muscle precursor called satellite cells. These satellite cells are important because they provide skeletal muscle with the ability to regenerate. Example, recover from injury. However, the cardiac muscle fibers do not contain satellite cells, and therefore these heart muscle cells have a limited regeneration capacity. Although the heart muscle and the skeletal muscle differ in many ways, they are also similar in several ways. For example, both heart and skeletal muscle fibers are serrated and contain the same contractile proteins, actin and myosin. Further, both heart and skeletal muscle require calcium to activate the myofilaments. Both fibers contract via the sliding filament model contraction. In addition, like the skeletal muscle, the heart muscle can alter its force of contraction as a function of degree of overlap of the actin and myosin filaments due to the changes of fiber length. Table 1 contains the point-by-point comparison of the structural and functional similarities and the differences between the cardiac muscle and the skeletal muscle. Table 9.1. The comparison and structural and functional differences/similarities between heart muscle and skeletal muscle. Structural comparison. Contractile proteins, actin and myosin. Present. Shape of muscle fibers. Shorter than skeletal muscle fibers and branching. Elongated, no branching. Nuclei single, multiple. Zetas present. Serrated, yes. Cellular functions, yes. Intercellular discs. No functional complexes. Connective tissue, endomysium, perimysium, and endomysium. Functional comparison. Energy production, aerobic primary, aerobic and anaerobic. Calcium source support contraction. Sarcoplasmic reticulum and extracellular calcium. Sarcoplasmic reticulum. Neural control, involuntary, voluntary. Regeneration potential, none. No satellite cells present. Sometimes some possibilities via satellite cells. Cardiac cycle. The cardiac cycle refers to the repeating pattern of the concentration and relaxation of the heart. The contraction phase is called the systole, and the relaxation period is called the diastole. Generally, when the terms are used alone, they refer to contraction and relaxation of the ventricles. However, note that the atria also contract and relax. Therefore, there is atrial, systole, and diastole, and atrial contraction. Atrial contraction occurs during ventricular diastole, and the atrial relaxation occurs during ventral systole. The heart is thus a two-step pumping action. The right and left atria contract together, which empties the blood into the ventricles. Approximately 0.1 1 second after the atrial contraction. The ventricles contract and deliver blood into both the systemic and pulmonary circuits. At rest, the contraction of the ventricles during the systoles ejects about two-thirds of the blood out of the ventricles, leaving about one third in the ventricles. The ventricles fill with blood during the next diastole. A healthy 21-year-old female might have an average resting heart rate of 75 beats per minute. This means that the total cardiac cycle lasts 0.8 seconds, with 0.5 seconds spent on diastole and the remaining spent dedicated to systole. See figure 9.5. 9.5. Illustration of cardiac cycle at rest during exercise. Note that increases in heart rate during exercise are achieved primarily through a decrease in time spent in diastole. However, at high heart rates, the length of time spent in systole also decreases. Rest heart rate equals 75 beats per minute. Heavy exercise heart rate equals 180 beats per minute. If the heart rate increases from about 75 beats per minute to 108 beats per minute, heavy exercise, there is a reduction in time spent in both systole and diastole. This point is illustrated in figure 9.5. And note that a rising heart rate results in a greater time reduction in diastole, whereas systole is less affected. Pressure changes during cardiac cycle. During the cardiac cycle, the pressure within the heart chamber rises and falls. When the atria are relaxed, blood flows into them. Flows into them from the venous circulation. As these chambers fill, the pressure inside gradually increases. Approximately 70% of the blood entering the atria during diastole flows directly into the approximately 70% of the blood entering the atria during diastole directly flows into the ventricles through the atrioventricular valves before the atria contract. Upon the atrial contraction, atrial pressure rises and forces most of the remaining 30% of atrial blood into the ventricles. Before pressure in the ventricles is low while they are filling, but when the atria contract, the ventricular pressure increases slightly. Then, as the ventricles contract, the pressure rises rapidly, which closes the atrioventricular valves and prevents black flow into the atria. As soon as the ventricular pressure exceeds the pressure of the pulmonary artery and the aorta, the pulmonary and aortic valves open and the blood is forced into the both pulmonary and systemic circulations. Figure 9.6 illustrates the changes in ventricular pressure as a function of time during the resting cardiac cycle. Figure 9.6. The relationship among pressure, volume, and heart sounds during the cardiac cycle. Notice the change in ventricular pressure and the volume during the transition from systole to diastole. Pressure, volume, time in seconds. Note that the occurrence of the two heart sounds that are produced by the closing of the atrioventricular valves, first heart sound, and the closing of the aortic. Note the occurrence of the two heart sounds that are produced by the closing atrioventricular valves, the first sound, and the closing of the aortic and pulmonary valves, the second sound. Arterial blood pressure. Blood pressure throughout the vascular system. Blood exerts pressure throughout the vascular system, but is greatest within the arteries, where it is generally measured and used as an indication of health. Blood pressure is the force exerted by blood against the arterial walls and is determined by how much blood is pumped and the resistance to blood flow. Arterial blood pressure can be estimated by the use of the sphygmometer. See closer look 9.1. A closer look 9.1. The measurement of arterial blood pressure. Arterial blood pressure is not usually measured directly, but is established using an instrument called a sphygmometer. Figure 9.7. A sphygmometer is used to measure arterial blood flow. No sound is heard because there is no blood flow when the cuff pressure is high enough to keep the brachial artery closed. Systolic pressure is the pressure at which a coronary sound is first heard. When the cuff pressure decreases and no longer able to keep the brachial artery closed during systole. Blood is pushed through the partially open brachial artery to produce the turbulent blood flow and a sound. The brachial artery remains closed during diastole. 3. The cuff pressure continues to decrease. The brachial artery opens even more during systole. At first, the artery is closed during diastole, but as the cuff pressure continues to decrease, the brachial artery partially opens during diastole. The turbulent blood flow during systole produces cough sounds, although the pitch of the sounds changes as the artery becomes open. In the pressure at which the sound disappears, eventually cuff pressure decreases below that pressure to the brachial artery and it remains open during systole and diastole. Non-turbulent flow is established and no sound is heard. Systolic pressure, 120 milligrams of mercury. Diastolic pressure, 180 grams of mercury. This device consists of an inflatable arm cuff connected to the column of mercury. The cuff can be inflated by a bulb pump with the pressure in the cuff measured by raising the column of mercury. For example, the pressure of 100 milligrams of mercury would be enough to raise the column of mercury upward a distance of 100 millimeters. Blood pressure is measured in the following way. The rubber cuff is placed around the upper arm so it surrounds the brachial artery. Air is pumped into the cuff until the pressure around the arm exceeds the arterial pressure. Because the pressure applied around the arm is greater than the arterial pressure, the brachial artery is squeezed shut and blood flow is stopped. If a stethoscope is placed over the brachial artery just below the cuff, no sounds are heard. Since no blood flow since there is no blood flow. However, if the air pressure however, if the air control valve is slowly open to release air, the pressure in the cup begins to decline, and the pressure around the arm quickly reach a point that is just slightly below the arterial pressure. At this point, blood begins to spurt through the artery, producing the turbulent flow, and a sharp sound known as a Corot cough sounds that can be heard through the stethoscope. The pressure example height of mercury column, at which the first tapping sound is heard, represents the systolic blood pressure. As the cuff pressure continues to decline, a series of increasingly louder sounds can be heard. When the pressure in the cuff is equal to a slightly below diastolic blood pressure, the sound heard through the stethoscope ceases because the turbulent blood flow increases. Therefore, the resting diastolic pressure represents the height of the mercury column when the sounds disappear. When the sounds disappear. The normal blood pressure of an adult male is 120 over 80, while the adult female tends to be lower at 110 over 70. The larger number in the expression of the blood pressure is systolic pressure expressed in millimeters of mercury. The lower number in the blood pressure ratio is diastolic pressure. Again, expressed in millimeters of mercury. Systolic blood pressure is the pressure generated as blood is ejected from the heart during ventricular systole. During ventricular relaxation, diastole, the arterial blood pressure decreases and represents the diastolic blood pressure. The difference between the systolic and diastolic blood pressure is called the pulse pressure. The difference between the systolic and diastolic blood pressure is called the pulse pressure. The average pressure during a cardiac cycle is called the average pressure during a cardiac cycle is called the mean arterial pressure. Mean arterial blood pressure is important because it determines the rate of blood flow through the systemic circuit. Determination of mean arterial blood pressure is not easy. It is not simple to average the systolic and diastolic pressure because diastole is generally lasts longer than the systole. However, mean arterial blood pressure can be estimated at rest in the following way. Mean arterial blood pressure equals D diastolic blood pressure plus 0.3 pulse pressure. Here, diastolic blood pressure is diastolic blood pressure, and the pulse pressure is the difference between systolic and diastolic pressures. Let's consider the simple calculation of mean arterial blood pressure at rest. For example, suppose an individual has a blood pressure of 120 divided by 180 over 180 milligrams of mercury. The mean arterial pressure would be mean arterial pressure equals 80 milligrams of mercury plus 0.33 120 minus 80 equals 93 milligrams of mercury. Note that the equation cannot be used to compute mean arterial blood pressure during exercise because it is based on the timing cardiac cycle at rest. That is, arterial blood pressure rises during systole and falls during diastole across the cardiac cycle. Therefore, there is to accurately estimate the average arterial blood pressure at any time. Systolic and diastolic blood pressure must be measured, and the amount of time spent in both systole and diastole must be known. To recall that the time spent in systole and diastole differs between the rest and exercise. For example, the formula estimates that the time spent in systole occupies 33% of the total cardiac cycle at rest. During during maximal exercise, systole may account for 66% of the total cardiac cycle. Therefore, the formula is designed to estimate the mean arterial blood pressure must be adjusted to reflect the time spent in systole and diastole. The high blood pressure, called hypertension, is classified as blood pressure as blood pressures above high blood pressure. Hypertension is classified as blood pressures above 140 over 90 milligrams of mercury. Unfortunately, approximately 33% of all adults greater than 20 years old in the United States have hypertension. Hypertension is generally classified into two categories: primary or essential hypertension, and two, secondary hypertension. The cause of primary hypertension is multifactorial. That is, there are several factors whose combined effects produce hypertension. This type of hypertension constitutes 95% of all reported cases in the United States. Secondary hypertension is a result of some known disease, and thus hypertension is secondary to another disease. Secondary primary is multifactorial. That is, several factors whose combined effects produce hypertension. Hypertension can lead to a variety of health problems. For example, hypertension increases the workload of the left ventricle, resulting in an adaptive increase in muscle mass of the left heart, called left ventricular hypertrophy. For example, hypertension increases workload of the left ventricle, resulting in an adaptive increase in muscle mass of the left heart, called the left ventricular hypertrophy. In early cases of hypertension and induced left ventricular hypertrophy, the increase in cardiac mass helps to maintain the heart's pumping ability. However, with time, this left ventricular hypertrophy changes the organization and function of the cardiac muscle fibers, resulting in a diminished pumping capacity of the heart, which can lead to heart failure. Further presence of hypertension is a major risk of developing atherosclerosis and the heart attacks. Finally, thickening of the heart walls and heart attacks. Finally, hypertension also increases the risk of kidney damage and rupture of the cerebral blood vessels, resulting in localized brain injury, stroke. Factors that influence arterial blood pressure. Mean arterial blood pressure is determined by two factors: cardiac output and total vascular resistance. Cardiac output is the amount of blood pumped from the heart. The total vascular resistance is the sum of resistance to blood flow provided by the systemic blood vessels. Mathematically, mean arterial blood pressure is defined as a product of cardiac output times total vascular resistance, as given in the following equation: mean arterial blood pressure, cardiac output times total vascular resistance. Therefore, an increase in either cardiac output or vascular resistance results in an increase in mean arterial blood pressure. In the body, mean arterial blood pressure depends on a variety of physiological factors, including cardiac output, blood volume, resistance to flow, and blood viscosity. Mean arterial blood pressure depends on a variety of physiological factors, including cardiac output, blood volume, resistance to flow, and blood viscosity. These relationships are summarized in Figure 9.8. An increase in any of these variables results in an increase in arterial blood pressure. Blood volume increases, blood pressure increases, heart rate increases, stroke volume increases, blood viscosity increases, peripheral resistance increases. These relationships are summarized in Figure. Conversely, a decrease in any of these variables decrease causes a decrease in blood pressure. The relationship between these factors will be discussed in detail in the later section. How blood pressure is regulated. Acute, short-term regulation of blood pressure is achieved by the sympathetic nervous system, whereas a long-term regulation of blood pressure is primarily a function of the kidneys. The kidneys regulate blood pressure by controlling the blood volume. Pressure receptors called baroreceptors in the carotid artery and the aorta are sensitive to changes in arterial blood pressure, and an increase in arterial blood pressure triggers the receptors to send impulses to the cardiovascular control center located within the medulla oblongata, which responds by decreasing the sympathetic activity. A reduction in sympathetic activity may lower the cardiac output and reduce the cardiovascular resistance, which in turn lowers blood pressure. Conversely, a decrease in blood pressure results in a reduction of baroreceptor activity. And baropressure activity to the brain. This causes a cardiovascular control center to respond by increasing sympathetic flow. Conversely, decreases in blood pressure. This causes a cardiovascular control center to respond by increasing sympathetic outflow, which raises the blood pressure back to normal. For a complete discussion of blood pressure regulation, see Hall and suggested readings. Electrical activity of the heart. Many of the myocardial cells have the unique potential for spontaneous electrical activity. Example has each has an eccentric rhythm. Example has an eccentric rhythm. However, in the normal heart, spontaneous electrical activity is limited to a special region located in the right atrium. This region is called the Circulatory node, or AV node, serves as a pacemaker for the heart. See Figure 9.9. Conduction system of the heart. Atrial SI node, left atrium, left ventricle, apex, Parasympathetic Fibers, atrioventricular, AV bundle, left and right bundles. Action potentials originate in the SI node, the pacemaker, and travels across the wall of the atrium arrows from the SI node to the atrioventricular node. Action potentials pass through the atrioventricular node along the atrioventricular bundle, which extends from the atrial node through the fibrous skeleton into the interventricular septum. The AV bundle divides into the right and left bundles, and the action potentials descend to the apex of each ventricle along the bundle branches. Action potentials are carried by the perijunctional fibers from the bundle branches to the ventricular walls. Spontaneous electrical activity in the SA node occurs due to the delay of the resting membrane potential. Occurs due to the delay of resting membrane potential and via inward diffusion of sodium during diastole. When the SA node reaches the depolarization threshold and fires, the wave of depolarization spreads over the atria, resulting in the atrial contraction. The wave of atrial depolarization cannot directly cross into the ventricles, but must be transported by way of specialized conductive tissue. This is a specialized conductive tissue radiates from the small mass of muscle called the conductive tissue radiates from the small mass of muscle called the atrioventricular node. This specialized conductive tissue radiates from the small mass of muscle called the atrioventricular node. This node, located in the floor of the right atrium, connects the atria with the ventricles by a pair of conductive pathways called the right and left bundle fibers. Note that the atrial-mediated depolarization of the AV node is delayed approximately 0.1 second. This time delay is important because it allows the atrial contraction to empty arterial blood into the ventricles prior to ventricle depolarization and contraction. Upon reaching the ventricles, these conductive pathways branch into smaller fibers called perijunctional fibers. The fibers then spread the wave of depolarization throughout the ventricles. A recording of electrical changes occur in the myocardium during the cardiac cycle is called the electrocardiogram, or ECG or EKG. An analysis of each EKG waveforms allows the physician to evaluate the heart's ability to conduct impulses and therefore determine if the electrical problems exist. Further analysis of the EKG during exercise is often used in diagnosis of coronary artery disease. See a closer look 9.2. Diagnostic use of EKG during exercise. Cardiologists are physicians who specialize in diseases of the heart and vascular system. One of the diagnostic procedures commonly used to evaluate cardiac function is to make an EKG measurements during an incremental exercise test, commonly called a stress test. This allows the physician to observe changes in the blood pressure as well as changes in the patient's ECG during periods of exercise-induced stress. The most common cause of heart disease is a collection of fatty plaque called atherosclerosis in the side of the coronary vessels. This collection of plaque reduces blood flow to the myocardium. The adequacy of the blood flow to the heart is relative to it depends on the metabolic demand placed on the heart. For example, small such as the coronary artery may permit adequate blood flow to meet the metabolic needs during rest. but coronary blockage would likely result in an inadequate blood flow to the heart during exercise because of large increase of metabolic demands. Therefore, a degraded exercise test may serve as a stress test to evaluate cardiac function. An example of abnormal exercise EKG is illustrated in Figure 910. Figure 910: depression of the ST segment of the electrocardiogram results in myocardial ischemia. Inadequate blood supply to part of the organ, especially the heart muscles. Myocardial ischemia, reduced blood flow, may be detected by changes in the ST segment of the ECG. Note the depressed notice the depressed ST segment in the picture on the right when compared to the normal ECG on the left. This ST segment depression suggests that the ischemic heart may be present and additional diagnosis procedures may be warranted. Figure 911 illustrates the normal EKG pattern. Figure 911, normal electrocardiogram during rest. P wave, PR, interval Q, S, R, RST, PQ, RST, PQ segment, QRS interval, ST segment. Notice that each ECG pattern contains several different deflections or waves during a cardiac cycle. Each of these distinct waveforms is identified by different letters. The first detection of an EKG is called deflection on the EKG is called the P wave and represents the depolarization of the atria. The second wave is called the QRS complex, represents the depolarization of the ventricles and occurs approximately 0.1 second following the P wave. The final deflection, the T wave, is a result of ventricular repolarization. Notice that atrial repolarization is usually not visible. It's usually not visible on the EKG because it occurs at the same time as the QRS complex. Figure 912. 912. An illustration of the relationship between the heart's electrical events and the recording of the ECG panels 1 to 2 illustrate the arterial depolarization and the formation of the P wave. Panels 3 to 4 illustrate ventricular depolarization and formation of the QRS complex. Finally, panels 5 and 6 illustrate the repolarization of the ventricles and formation of the T wave. That is, arterial repolarization is hidden by the QRS complex. Finally, figure 913 illustrates the relationship between the changes in intraventricular pressure and the EKG. The relationship between the changes in intraventricular pressure and the EKG. Notice that the QRS complex, example, depolarization of the ventricles, occurs at the beginning of systole. At the beginning of systole, and the rise of ventricular pressure. Intraventricular pressure rises as the ventricles contract. Intraventricular falls as the ventricles relax. AB waves close. Arterial ventricular valves close. Arterial semilunar valves close. Further, note the T-wave repolarization of the ventricles occurs at the same time that the ventricles relax at the beginning of diastole. Note that the QRS complex, example, depolarization of the ventricles, occurs at the beginning of the systole, whereas T-wave, example, repolarization of the ventricles, occurs at the beginning of the diastole. Also, notice that the arterial repolarization is usually not visible on the EKG because it occurs at the same time as the QRS complex. Also, notice that the intraventricular pressure between beginning of the systole results in the first sound due to the closure of the atrioventricular valves, AV valves, and the fall in intraventricular valves at the end of the systole results in the second heart sound due to the closure of the aortic pulmonary semilunar valves. In summary, the myocardium is composed of three layers: the epicardium, the outer layer; the myocardium, the middle layer, composed of the cardiac muscle and fibers, and the endocardium, inner layer. The contraction phase of the cardiac cycle is called the systole, and the relaxation period is called the diastole. The average blood pressure during a cardiac cycle is called the mean arterial blood pressure. Blood pressure can be increased by one or all of the following factors: increase in blood volume, increase in heart rate, increase in blood viscosity, increase in stroke volume, increase in peripheral resistance. The pacemaker of the heart is the SA node. A recording of the electrical activity of the heart during cardiac cycle is called the electrocardiogram, or EKG. Cardiac output. Cardiac output, Q, is a product of the heart rate and stroke volume, the amount of blood pumped per heartbeat. Thus, the cardiac output can be increased due to a rise in either heart rate or stroke volume. During exercise in an upright position, example running or cycling, an increase in cardiac output is due to an increase in both heart rate and stroke volume. Table 9.2 presents typical values at rest during maximal exercise for heart rate, stroke volume, and cardiac output in both untrained and healthy endurance athletes. Table 9.2, typical resting and maximal exercise values for stroke volume, heart rate, and cardiac output for college-age untrained subjects and trained endurance athletes' body weights. Male equals 70 kilograms, female equals 50 kilograms. Rest. Heartbeats per minute. Stroke volume, milliliters per minute. Untrained male, untrained female. Trained. Trained female. Max exercise, untrained male. Q is what? Cardiac output. Cardiac output. Thus, the cardiac output can be increased due to either heart rate or stroke volume. During exercise in an upright position, okay, see, presents a typical values at rest during maximal exercise for heart rate and stroke volume and cardiac output in both untrained and highly trained endurance athletes. The gender difference in stroke volume and cardiac output is due mainly to differences in body size and between men and women. Regulation of heart rate. During exercise, the quantity During exercise, the quantity of blood pumped by the heart must change in accordance to the elevated skeletal muscle oxygen demand. Because the SA node controls the heart rate, changes in the heart rate often involve factors that influence the SA node. The most prominent factors that influence the heart rate are the parasympathetic and sympathetic nervous system. The parasympathetic fibers that supply the heart arise from neurons in the cardiovascular control center in the medulla oblongata and make up a portion of the vagus nerve. That supply the heart arise from the neurons in the cardiovascular control center in the medulla oblongata and make up the portion of the vagus nerve. Upon reaching the heart, these fibers make contact with both the SA node and the AB node. See figure 914. Figure 914. The activities of the SA and AB nodes can be altered by both the sympathetic and parasympathetic nervous systems. Cerebrum, choral section, hypothalamus, medulla oblongata, transverse section, cardiac center, spinal cord, transverse sections, choroid, sinus, choroid, bioreceptors, common carotid artery, sensory fibers, aortic bioreceptors, AV node, SA node, sympathetic, parasympathetic, sympathetic trunk. When stimulated, these nerve endings release acetylcholine, which causes a decrease in activity of both the SA and AV nodes due to hyperpolarization. Example, moving the resting membrane potential further from the threshold. The end result is reduction of the heart rate. Therefore, the parasympathetic nervous system acts as a braking system to slow down the heart rate. Even at rest, the vagus nerves carry impulses to the SA and AV nodes. This is often referred to as the vagus nerve carries impulses to the SA node and AV nodes. This is often referred to as the parasympathetic tone. As a consequence, changes in parasympathetic activity can cause the heart rate to increase or decrease. For instance, a decrease in parasympathetic tone to the heart can elevate heart rate, whereas an increase in parasympathetic activity can cause a slowing of the heart rate. The initial increase of heart rate during low intense exercise is up to approximately 100 beats a minute. The initial increase in heart rate during low intensity exercise up to approximately 100 beats per minute is due to the withdrawal of parasympathetic tone. This occurs because without neural input to the SA node, the intrinsic firing rate of the SA node is typically 100 beats per minute. At higher work rates, the stimulation of the SA and AV nodes by the sympathetic nervous system is responsible for the increase in the heart rate. This occurs because without neural input to the SA node, the intrinsic firing rate of the SA node is typically 100 beats per minute. At higher work rates, the stimulation of the SA and AV nodes by the sympathetic nervous system is responsible for increases in heart rate. The sympathetic fibers reach the heart by the means of the cardiac accelerator nerves, which innervate both the SA node and ventricles. Endings of these fibers release norepinephrine upon stimulation, which act on the beta receptors in the heart and cause an increase in both heart rate and the force of myocardial contraction. See Clinical Applications 9.2. Clinical Application 9.2. Beta blockade and exercise heart rate. Beta blockade, beta and adrenergic blocking medications, beta blockers, are commonly prescribed to patients with coronary artery disease and/or hypertension. Although there are many different causes of these drugs, all these medications compete with the epinephrine and norepinephrine for beta adrenergic receptors in the heart. The end result is that beta blockers reduce the heart rate and the vigor of the myocardial contraction, thus reducing the oxygen requirement of the heart. In a clinical exercise physiology, it is important to appreciate that all beta blocking drugs will decrease resting heart rate as well as exercise heart rate. Indeed, individuals on beta blocking medications will exhibit a lower exercise heart rates during both submaximal and maximal exercise. This is an important fact that should be considered when prescribing exercise and interpreting the exercise test results of individuals using beta blocking medications. At rest, a normal balance between parasympathetic tone and sympathetic activity to the heart is maintained by a cardiovascular control center and the medulla oblongata. The cardiovascular control center receives impulses and various parts of the circulatory system relive relative to the changes in the important parameters, example blood pressure, blood oxygen tension, and the relays to motor impulses to the heart and response to the changing of a cardiovascular need. For example, an increase in resting blood pressure above normal pressure receptors in the carotid arteries of the arch of the aorta return in turn sent impulses to the cardiovascular control center. In response, the cardiovascular control center decreases the parasympathetic control to the heart and slow the heart rate and reduce cardiac output. The reduction of cardiac output causes the blood pressure to decline back toward normal. Another regulatory reflex involves pressure receptors located in the right atrium. In this case, an increase in right atrial pressure signals the cardiovascular control center that increase in venous return has occurred. Hence, to prevent backup of blood in the systemic venous system. An increase in cardiac output must result. The cardiovascular control center responds by sending sympathetic accelerated nerve impulses to the heart, which increase heart rate and cardiac output. The end result is an increase in cardiac output and lowers the right atrial pressure back to normal, and venous blood pressure is reduced. Finally, the change in body temperature can influence heart rate. An increase in body temperature above normal results in an increase in heart rate, whereas lowering body temperature below normal causes a reduction in heart rate. For example, exercise in a hot environment results in increased body temperatures and higher heart rates than if the same exercise was performed in a cool environment. This topic is discussed in more detail in Chapter 12. Heart rate variability. As discussed in previously, heart rate is regulated by the autonomic nervous system. Example, balance between the parasympathetic and sympathetic nervous systems. The term heart rate variability refers to the variation between the time between heartbeats. In practice, the time interval expressed in milliseconds between the two heartbeats can be measured as the RR time interval using the EKG tracing as illustrated in figure 911. The heart rate variability is calculated as a standard deviation of the RR time interval during a selected time period. The heart rate variability is calculated as a standard deviation of the heart rate variability is then calculated as a standard deviation of the RR time interval during a selected time period. A wide variation in heart rate variability is considered to be a good index of a healthy balance between the sympathetic and parasympathetic nervous system, whereas low heart rate variability indicates an imbalance and exists in an autonomic regulation. The physiological significance of the heart rate variability is that the time variation between the heartbeats reflects an autonomic balance and is an excellent non-invasive screening tool for many diseases. For example, low heart rate variability has been shown to predict future cardiovascular events such as sudden cardiac death. Further, low heart rate variability is an independent risk factor for development of cardiovascular disease, including heart failure, myocardial infarction, and hypertension. Epidemiological studies have also established that low heart rate variability is an excellent predictor of increased cardiovascular morbidity and mortality in patients with existing cardiovascular disease. What is the physiological cause of low heart rate variability? Again, the autonomic nervous system regulates many cardiovascular parameters, including both heart rate and heart rate variability. Recall that heart rate can be elevated by increasing the sympathetic activity and decreased by increasing the parasympathetic vagal activity. The balance between the effects of the sympathetic and parasympathetic systems, the two opposite acting branches of the autonomic nervous system, is referred to as the the balance between the effects of the the balance between the effects of the sympathetic and the parasympathetic systems, the two opposite acting branches of the balance between the effects of the sympathetic and parasympathetic systems, the two opposite acting branches of autonomic nervous system, is referred to as the parasympathetic balance and is reflected in the beat-to-beat changes of the cardiac cycle. Numerous factors can influence the the balance between the effect of sympathetic and parasympathetic systems, the two opposite acting branches of the autonomic nervous system, is referred to as the sympathopathovagal imbalance. And is referred to as the beat-to-beat changes in the cardiac cycle. Numerous factors can influence the sympathovagal balance and thus affect the heart rate variability. For example, with the advancing age of or some disease states, there is a decrease in parasympathetic tone at rest or an increase in sympathetic nervous system outflow. This results in a disturbance in the sympathovagal imbalance and decreases in the heart rate variability. Some specific examples of diseases that promote a decrease in heart rate variability are as follows. Heart rate variability is decrease in patients suffering from depression, hypertension, and heart disease, and individuals following myocardial infarction. Important research indicates that physical inactivity promotes the decrease in heart rate variability, whereas regular bouts of exercise results increased heart rate variability. Therefore, investigation of the types of exercise and specific training programs have positive influences of heart rate variability and has become an important area of research. Regulation of stroke volume. Stroke volume at rest during exercise is regulated by three factors. Stroke volume at rest or during exercise is regulated by three factors. 1. The end diastolic volume. End diastolic volume, which is the volume of blood in the ventricles at the end of the diastole. And 2. The average aortic blood pressure. And 3. The strength of ventricular contraction. End diastolic volume is often referred to as a preload. And it influences the stroke volume in the following way. The two physiologists, Frank and Sterling, demonstrated that the strength of the ventricular contraction increased with the enlargement of the end diastolic volume. Enlargement of the end diastolic volume. Example, stretch of the ventricles. This relationship has become known as the Frank-Starling law. Frank-Starling law. Of the heart. This increase of end diastolic volume results in a lengthening of cardiac fibers and improves the force of contraction, manner similar to that seen in the skeletal muscles, discussed in Chapter 8. The mechanisms to explain the influence of fiber length on a cardiac contractility is an increase in the length of cardiac fibers, increases the number of myosin cross cross-bridge interactions with actin, resulting in increased force reduction. A rise in cardiac contractibility results in the rise of the amount of blood pumped per beat. The relationship between and diastolic volume and stroke volume is illustrated in figure 915. 915, an illustration of the relationship between ventricular and diastolic volume and stroke volume. Notice the increased stroke volume when the venous return increases above normal resting level. Stroke volume, normal resting volume, increased venous return. The principal variable that influences the end diastolic volume is the rate of venous return to the heart. An increase in venous return results in a rise in end diastolic volume. An increase in venous return results in a rise in end diastolic volume, and therefore increases the stroke volume. The venous return and the resulting increase in end diastolic volume play a key role in the increase in stroke volume observed during upright exercise. What factors regulate venous return during exercise? There are three principal mechanisms. Constriction of the veins, venoconstriction, pumping action of a contractile skeletal muscle called the muscle pump, and the pumping action of the respiratory system called the respiratory pump. Vasoconstriction increases the venous return by decreasing the diameter of the vessels and increasing the pressure within the vein. The end result of the increased venous pressure is the drive blood back toward the heart. Venoconstriction occurs via a reflex sympathetic constriction of the smooth muscle in the veins during draining skeletal muscle, which is controlled by the cardiovascular control center. Muscle pump. The muscle pump is a result of the mechanical action of rhythmic skeletal muscle contractions. Therefore, when muscles contract during exercise, they compress veins and push blood backward toward the heart. Between contraction, blood fills the vein and the process is repeated. Blood is prevented from flowing away from the heart between the contractions by one-way valves located. Blood is prevented from flowing away from the heart between the contractions by one-way valves located in the large veins. Figure 916. The action of one-way venous valves, contraction of the skeletal muscles, helps pump blood toward the heart, but is prevented from pushing blood away from the heart by closure of the venous valves. During the sustained muscular contractions, asymmetric exercise, the muscle pump cannot operate, and venous return to the heart is reduced. Respiratory pump. The rhythmic pattern of breathing also provides the mechanical pump by which venous return is promoted. The respiratory pump works in the following way. During inspiration, the pressure within the thorax decreases, and abdominal pressure increases. This creates a flow of venous blood from the abdominal region into the thorax and therefore promotes venous return. Although quiet breathing rest aids in venous return, the role of the respiratory pump is enhanced during exercise due to the greater respiratory rate and depth. Indeed, recent evidence indicates the respiratory pump is the dominant factor that promotes venous return to the heart during upright exercise. A second variable affects stroke volume is the aortic pressure, mean arterial pressure in order to eject blood. The pressure is generated by the left ventricle must exceed the pressure in the aorta. Therefore, the aortic pressure or mean arterial pressure is called a second variable that affects stroke volume is the aortic pressure, mean arterial pressure. In order to eject blood, the pressure is generated by the left ventricle must exceed the pressure in the aorta. Therefore, aerobic pressure of the mean arterial pressure, called the afterload, preload. And the diastolic volume is often referred to as a preload. Therefore, aortic pressure or mean arterial pressure, called afterload, represents a barrier to the ejection of blood from the ventricles. Stroke volume thus inversely proportional to the afterload. That is, stroke volume is thus inversely proportional to the afterload. That is, an increase in aortic pressure produces a decrease in stroke volume. However, afterload is minimized during exercise due to the arterial dilation. This arterial dilation in the working muscles reduces the afterload and makes it easier for the heart to pump a large volume of blood. The final factor that influences stroke volume is the effect of circulating catecholamines. Example, epinephrine, and norepinephrine, and the direct sympathetic stimulation of the heart by the cardiac accelerator nerves. Both the mechanisms increase the cardiac contractibility by increasing the amount of calcium available to the myocardial cell. In the particular epinephrine and norepinephrine, both increase the entry of extracellular calcium into the cardiac muscle, which increases the cross-bridge activation and the force of production. The relationship between the sympathetic stimulation of the heart and the stroke volume is illustrated in figure 917. 917. Effects of the sympathetic stimulation of the heart on the stroke volume. Note that the sympathetic stimulation results in an increase in stroke volume at any given diastolic volume. That is, the sympathetic stimulation increases the ventricular contractibility via increased level of intracellular calcium, resulting in a higher myosin cross-bridge interaction with actin. Normal resting volume, increased contractibility, stroke volume, sympathetic stimulation. This relationship is illustrated. Notice the compared to control conditions. Example, sympathetic stimulation. Increased sympathetic stimulation of the heart increases stroke volume at any level of end diastolic volume. To summarize, stroke volume is regulated by three factors: end diastolic volume, cardiac contractibility, and the cardiac afterload. During the upright exercise, the exercise induced increases in stroke volume occur due to both increases in end diastolic volume and increases in cardiac contractibility to circulating catacombs and/or sympathetic stimulation. In contrast, an increase in cardiac afterload results in a decrease in stroke volume. In summary, cardiac output is the product of the heart rate and stroke volume. Q equals HR heart rate times stroke volume. Figure 918 summarizes the variables that influence cardiac output during exercise. The pacemaker of the heart is the SA node. The pacemaker of the heart is the SA node. The SA node activity is modified by the parasympathetic nervous system, slows heart rate, and the sympathetic nervous system increases heart rate. Heart rate increases at the beginning of the exercise due to withdrawal of the parasympathetic tone. Higher work rates, the increase in heart rate is achieved via increased sympathetic outflow to the SA nodes. Stroke volume is regulated via the end diastolic volume, afterload, and the example aortic blood pressure, and the strength of the ventricular contraction. Venous return during exercise is due to the basal constriction, the muscle pump, and the respiratory pump. Hemodynamics. One of the most important features of the circulatory system is a continuous closed loop. Blood flow through the circulatory system results from pressure differences between the two ends of the system. To understand the physical regulation of blood flow to the tissues, it's necessary to appreciate the interrelationship between the pressure, flow, and resistance. The study of these factors and the physical principles of blood flow is called hemodynamics. The physical characteristics of blood. Blood is composed of two principal components, plasma and cells. Plasma is the watery portion of the blood that contains numerous ions, proteins, and hormones. The cells that make up the blood are red blood cells, platelets, and white blood cells. Red blood cells contain hemoglobin used for transport of oxygen. Platelets play an important role in blood clotting. White blood cells are important in preventing infection. The percentage of blood is composed of cells is called the hematocrit. The percentage of blood that is composed of cells is called hematocrit. That is 42% of the blood cells is that is 42% of the blood is cells, and the remainder is plasma. The hematocrit is 42%. See figure 9.19. Factors that regulate cardiac output. Variables that stimulate cardiac output are shown by the solid arrows. Parasympathetic nerves, sympathetic nerves, contraction, strength, endodiastolic volume, mean arterial pressure, stroke volume, stretch, Frank, Starling. Blood cells become packed at the bottom of the test tube when the blood is centrifuged. This leaves the plasma at the top of the tube. The percentage of the whole blood that is composed of cells is termed hematocrit. White blood cells, red blood cells, plasma, percent hematocrit. On the percentage basis, red blood cells constitute the largest fraction of cells found in the blood. Therefore, hematocrit is principally influenced by the increases or decreases in the red blood cells numbers. The average hematocrit of a normal college-age male is 42% hematocrit. Of the normal college-age female, the averages approximately 38%. These values vary among individuals and are dependent on the number of variables. The blood is several times more viscous than water, and the viscosity increases the difficulty in which the blood flows through the circulatory system. One of the major contributors to the viscosity is the concentration of red blood cells found in the blood. Therefore, during periods of anemia, decreased red blood cells, the viscosity of the blood is lower. Conversely, an increase in hematocrit results in the elevation of blood viscosity. The potential influence of changing blood viscosity on the performance is discussed in chapter 25. Relationship among pressure and resistance flow. As mentioned earlier, blood flow through the vascular system is dependent upon the differences in pressure at the two ends of the system. For example, if the pressures at the two ends of the vessel are equal. If the pressures at the two ends of the vessel are equal, no flow will occur. In contrast, if the pressure is higher at one end of the vessel than the other, the blood will flow in the region of the higher pressure and the region of the lower pressure. The rate of flow is proportional to the pressure difference, P1 minus P2, between the two ends of the tube. In other words, the blood flow is directly related to the pressure differences across the tube, whereby an increase in the driving pressure will increase flow. Figure 920 illustrates the pressure head. The flow of blood through the systemic circuit is dependent on the pressure difference, changes in pressure between the aorta and the right atrium. In this illustration, the mean pressure in the aorta is 100 milligrams of mercury, while the pressure in the right atrium is 0 grams of mercury. Therefore, the driving pressure across the circuit is 100 milligrams. 100 minus 1 minus 0 equals 100. Pressure equals 0 milligrams. Right atrium, right ventricle, left atrium, left ventricle. Mean arterial pressure, approximately 100. Okay. Figure 920 illustrates the pressure head driving blood flow in a systemic circulatory system under resting conditions. Here, the mean arterial pressure is 100 milligrams. Example, this pressure of blood in the aorta. The pressure is opposite end of the circuit. Example, the right atrium is 0 milligrams of mercury. Therefore, the driving pressure across the circulatory system is 100 milligrams of mercury. 100 minus 0 equals 100. It should be pointed out that the flow rate of blood through the vascular system is proportional to the pressure difference across the system, but inversely proportional to the resistance. It is simple terms that this means that when the vascular resistance increases, blood flow decreases. Inversely proportionally proportionally is expressed mathematically by the placement of this variable in the denominator of the fraction, because the fraction decreases when the denominator increases. Therefore, the relationship between blood flow, pressure, and resistance is given by the equation. Blood flow equals change in pressure over resistance, where triangle pressure means the difference in pressure between the two ends of the circulatory system. Therefore, blood flow can be increased by either an increase in blood pressure or a decrease in the resistance. A fivefold increase in blood flow could be generated by increasing pressure by a factor of 5. However, this large increase in blood pressure would be hazardous to health. Fortunately, increases in blood flow during exercise are achieved primarily by a decrease in resistance with a small rise in blood pressure. Fortunately, increases in blood flow during exercise are achieved primarily by a decrease in resistance with small rise in blood pressure. What factors contribute to resistance of blood flow? Resistance to flow is directly proportional to the length of the vessel and viscosity of the blood. However, the most important variable determining vascular resistance is the diameter of the blood vessel, because vascular resistance is inversely proportional to the fourth power of the radius of the vessel. Resistance equals length times viscosity to radius to the fourth power. In other words, an increase in either vessel length or blood viscosity results in a proportional increase in resistance. However, reducing the radius of the blood vessel by 1/2 would increase the resistance 16-fold. Example, 2 to the 4th equals 16. Sources of the vascular resistance. The viscosity of the blood and the length of the blood vessels are not manipulated in normal physiology. Therefore, the primary factor regulating blood flow through the organs is the diameter of the blood vessel. Indeed, a small decrease in the radius of the blood vessel, basal constriction, results in a large increase in vascular resistance and decrease in blood flow. Specifically, the effect of changes in radius on the changes in the flow rate are magnified by the power of 4. And therefore, blood can be diverted from one organ system to another by varying degrees of basal constriction and vasodilation. The principle is used during heavy exercise to divert blood toward contracting skeletal muscle and away from the less active tissue. This concept is discussed in detail in the next section. Changes in oxygen delivery to muscle during exercise. The greatest vascular resistance to blood flow occurs in the arterioles. This point is the greatest vascular resistance in blood flow occurs in the arterioles. This is illustrated in figure 921. The pressure changes across the systemic circulation. Notice the large pressure drop across the arterioles. Left ventricle, large arteries, arterioles, precapillary, sinus capillaries, venules, large veins. The greatest vascular resistance in blood flow occurs in the arterioles. Pressure changes across systemic circulation. Notice the large drop across in the arterioles. Across the arterioles, approximately 70 to 80% of the decline in mean arterial pressure occurs across the arterioles. In summary, blood is composed of two principal components, plasma and cells. Blood flow through the vascular system is directly proportional to the pressure at the two ends of the system, inversely proportional to the resistance. The most important factor of determining resistance is the blood flow to resistance to blood is the flow and radius of the blood vessel, the relationship between the vessel radius. The most important factor determining resistance to blood flow is the radius of a blood vessel. The relationship between blood vessel radius, blood vessel length, blood viscosity, and flow is resistance length times viscosity, the radius of the force. The greatest vascular resistance of blood flow is offered in the arterioles. Changes of oxygen delivery to muscle. During intense exercise, the metabolic need for oxygen in skeletal muscle increases many times over the resting values. To meet the rise in oxygen demand, blood flow is to the contracting muscle must increase. As mentioned earlier, increased oxygen delivery to the exercising skeletal muscle is accomplished via two mechanisms: an increase in cardiac output and a redistribution of flow from the inactive organs to the working skeletal muscle. Changes in cardiac output during exercise. Cardiac output increases during exercise in direct proportion to metabolic rate required to perform the exercise task. This is shown in figure 922. 922. Changes in blood pressure, stroke volume, cardiac output, heart rate, and arterial mix, venous oxygen differences in function of relative work rates. See text for details. Blood pressure, systolic, mean, diastolic, stroke volume, 40% VO2 max, cardiac output, up, heart rate, up, arterial, venous, up. Note that the relationship between cardiac output and percent maximal oxygen uptake is essentially linear. The increase in cardiac output during exercise in the upright position, example running and cycling, is achieved by increasing both increase in both stroke volume and heart rate. However, an untrained or moderately untrained subject, stroke volumes does not increase beyond a workload of 40% to 60% VO2 max. Figure 9.22. Therefore, work rates greater than 40 to 60% VO2 max, the rise of cardiac output in individuals is achieved by increases in heart rate alone. The example presented in figure 922 for maximal heart rate, stroke volume, cardiac output are typical of values for a 70 kilogram active but not highly trained college-age male. See Table 9.2 for examples of maximal stroke volume and cardiac output for trained men and women. Table 9.2. Note that although most of the experts agree that stroke volume reaches a plateau between 40 to 60% of VO2 max during upright exercise in untrained and moderately trained individuals, evidence exists that stroke volume does not plateau in a highly trained athletes during running exercise. This point is discussed in a more detail in Research Focus 9.1. Research Focus 9.1. It is widely accepted that during incremental exercise, stroke volume in active or untrained subjects reaches a plateau at a solid maximal work rate. Example, approximately 40 to 60% VO2 max, figure 922. The physiological explanation for this plateau is stroke volume at a high heart rates. The time available for the ventricular filling decrease. Therefore, the end diastolic volume reaches a plateau and may decrease slightly at a high exercise intensities. However, new evidence suggests that during incremental work rates, the stroke volume of endurance athletes, example, highly trained distance runners, does not plateau, but it continues to increase to VO2 max. What is the explanation of this observation? It appears that compared to untrained subjects, endurance athletes have improved ventricular filling during heavy exercise due to increased venous return. This increase in diastolic volume results in an increased force of ventricular contraction, Frank's starting law, and increase in stroke volume. The relationship between the two physiologists demonstrated that the strength of ventricular contraction increases with an enlarged end diastolic volume. This point, further differences exist in exercise-induced changes in a stroke volume between upright exercise, example running, and supine exercise, example swimming. See a closer look, 9.3 for more details. Impact of body composition on stroke volume during exercise. Body position has a major influence on stroke volume at rest and during exercise. Because of the effect of gravity on venous return to the heart. Indeed, in the upright position, standing at rest, gravity promotes blood pooling in the legs. This results in reduced venous return to the heart and a reduced end diastolic volume, with the outcome being a smaller stroke volume because of the Frank Starling law of the heart. However, compared to rest exercise in the upright position, example running or cycling, results in an increased venous return, a larger end diastolic volume, and improved stroke volume. For example, in untrained individuals, stroke volume is typically 60 to 80 milligrams per beat at rest, but stroke volume can increase by 100% during intense exercise due to an increased venous return. In contrast to the exercise in the upright position, intense exercise in supine position, example swimming, results in only small increases in, example 20 to 40% in stroke volume above resting conditions. The explanation for the difference in stroke volume between exercise in the upright position and the supine position is as follows. When the body is resting in the supine position, blood does not pool in the legs, and therefore venous return to the heart is not impeded. So compared to the upright position, the end diastolic volumes and the stroke volumes are significantly higher in the supine position. Therefore, the cause in stroke volume is already high in the supine position, and the increase in stroke volume that occurs during swimming exercise is not as great, and an increase in stroke volume that occurs during upright exercise. In summary, differences in the resting and diastolic volume and the stroke volume account for variations of exercise-induced increases in stroke volume between swimming and upright exercises such as swimming or cycling. Maximal cardiac output tends to decrease in linear fashion in both men and women after 30 years of age. This is primarily due to decrease in maximal heart rate with age. For example, because cardiac output equals heart rate times stroke volume, and any decrease in heart rate would result in decrease in the cardiac output. The decrease in maximal heart rate with age in young adults can be estimated by the following formula. Max heart rate equals 220 minus age, years. According to the formula, a 20-year-old subject might have a maximal heart rate of 200 beats per minute, whereas a 35-year-old would have a maximal rate of 185 beats per minute. However, this is only an estimate, and values can be 20 beats times per minute, higher or lower. The previous formula for adults is not a good predictor of maximal heart rate in older adults or children. In adults greater than 4 years old and children ages 7 to 17, the formula can be used to predict maximal heart rate. Maximal heart rate 208 minus 0.7 age, years. According to this formula, children at 12-year-old child would have a maximal heart rate of 200 beats, similar to the formula used predict maximal heart rates for young adults. The formula for children and older adults provides only an estimate of maximal heart rates, and a wide variability in maximal heart rates can exist between the different individuals. Changes in arterial mixed venous O2 content during exercise. Figure 9.2 illustrates the exercise-induced changes in arterial mixed venous oxygen difference. A minus VO2 difference. Changes in muscle and spasmodic blood flow as a function of exercise intensity. Notice the large increase in muscle blood flow as the work rate increases. Relating to the visceral or internal organs. Or internal organs. The A minus VO2 differences represents the amount of O2 that's taken up from 100 milliliters of blood by the tissues during one trip around the systemic circuit. An increase in the A VO2 difference during exercise is due to the increase in the amount of O2 taken up and used for oxidative production of ATP by skeletal muscle. The relationship between cardiac output A minus VO2 difference and the oxygen uptake is given off by the Flick equation. Simply stated, the Flick equation says that VO2 is equal to the product of cardiac output and the A mean VO2 minus mean VO2 difference. Illustrates the induced changes in arterial mixed venous oxygen difference. This means that that either in the cardiac output of arterial mean oxygen difference would elevate VO2. Figure 922 illustrates that during exercise, oxygen consumption increases due to both an increase in cardiac output and an increase in arterial VO2 difference. During distribution of cardiac output during rest and maximal exercise. At rest, the cardiac output is 5 liters per minute, bottom of figure. During maximal exercise, the cardiac output increased 5-fold to 25 liters per minute, top figure. Note the large intestines in the blood flow to the skeletal muscle and the reduction in the flow of the liver GI tract. Up. Redistribution of blood flow during exercise. To meet the increased oxygen demand of the skeletal muscles during exercise, it is necessary to increase muscle blood flow while reducing blood flow to less active organs such as liver, kidneys, and GI tract. Figure 923 points out that the change in the blood flow to muscle and splenic pertaining to viscera. Splenic pertaining to viscera, circulation is decreased. Circulation is dedicated by the exercise intensity, metabolic rate. That is, the increase in muscle blood flow during exercise and the decrease in splenic blood flow change in the linear function of percent of VO2 max. Figure 924 illustrates the change in blood flow to various organ systems between the resting conditions and during maximal exercise. Several important notes need to be stressed. First, at rest, approximately 15 to 20%, 15 to 20% of the total cardiac output is just directed toward the skeletal muscle. However, during maximal exercise, 80 to 85% of the total cardiac output goes to the contracting skeletal muscle. This is necessary to meet the huge increase in muscle oxygen requirements during intense exercise. Second, notice that during a heavy exercise, the percentage of total cardiac output that goes to the brain I didn't know that. Second, notice the heavy cardiac output that goes to the brain is reduced during rest. However, the absolute blood flow that reaches the brain is slightly increased above resting values. This is due to the elevated cardiac output during exercise. Further, the percentage of total cardiac output that reaches the myocardium is the same during maximal exercise as is at rest. The total coronary blood flow is increased to the cardiac increase in the cardiac output during heavy exercise. Also note that the skin blood flow increases increases during light and moderate exercise, but decreases during maximal maximal exercise. Finally, compared to rest, blood flow to abdominal organs also decreased during maximal exercise. This reduction in abdominal blood flow during heavy exercise is an important means of shifting blood away from the less active tissues and toward the working skeletal muscles. Regulation of blood flow during exercise. What regulates blood flow to various organs during exercise? Muscle as well as other body tissues have an adequate ability to regulate their own blood flow in direct proportion to their metabolic needs. Blood flow to skeletal muscle during exercise is regulated in the following way. First, the arterioles in the skeletal muscle have a high vascular resistance at rest. This is due to adrenatic sympathetic stimulation, which causes the arterial smooth muscles to constrict, basal constriction. This reduces a relatively low blood flow to the muscle at rest, 4 to 5 milliliters per minute for 100 grams of muscle. But because two muscles have a large mass, this accounts for 20 to 25% total blood flow from the heart. During exercise, skeletal muscle flow increases and blood flow increases in direct proportion to metabolic demand. In fact, compared to blood flow at rest, blood delivery. In fact, compared to blood flow at rest, blood delivery to contracting muscle during exercise may rise 100 times. This increased muscle flow occurs because of the decrease in vascular resistance combined with the requirement of capillaries in the skeletal muscles. At rest, only 50% to 80% of the capillaries in the skeletal muscle are open at a time. However, during intense exercise, almost all the capillaries in contractile muscles are open, resulting in increased oxygen delivery to the contracting muscle fibers. The increase in muscle blood flow that occurs during regulated or that occurs during exercise are regulated by several factors that promote vasodilation. This type of blood flow regulation is termed autoregulation and is the most important factor in regulating blood flow to the muscle during exercise. This level of vasodilation occurs in the arterioles and small arteries leading to the skeletal muscle, leading to skeletal muscle, leading t- leading to the skeletal muscle is regulated by the metabolic rate. Example: oxygen and nutrients needed of the muscle. Specifically, the intensity of the exercise and the number of motor units recruited determine the overall need for blood flow to the muscle. For example, during low intensity exercise, a relatively small number of motor units is recruited into the action, resulting in a relatively small demand for blood flow to the contracting muscle. In contrast, high intensity exercise results in a recruitment of large number of motor units and therefore results in a large increase in muscle blood flow. What factors are responsible for auto-regulation of muscle blood flow to match the metabolic demand? Skeletal muscle blood flow is controlled by an interaction between several locally formed vasodilators, including nitric oxide, prostaglandins, ATP, adenosine, and endothelium-derived hyperpolarization factors. Further, separate from these substances that promote vasodilation, some are locally subunits and inhibit the vasoconstrictor and increase sympathetic nerve activity during exercise. The local inhibition of the sympathetic induced vasoconstriction that occurs during exercise is called the local inhibition of a sympathetic induced vasoconstriction that occurs during exercise is called the sympatholysis and increases muscle blood flow during exercise. The relative importance of this phenomenon on the control of muscle blood flow continues to be debated topic. Let's discuss the local factors that involved in the control of muscle blood flow during exercise in a more detail. The increased metabolic rate of skeletal muscle during exercise causes local changes as increased local changes such as increased production of nitric oxide, prostaglandins, ATP, adenosine, and endothelium derived from hyperpolarization factors. Each of these factors has been independently shown to promote vasodilation by increasing smooth muscle relaxation in the arterioles. For example, both nitric oxide and prostaglandins, example, protest protestilin, are potent vasoconstrictors. Further, both ATP and adenosine are important vasodilators and increase muscle blood flow during exercise. Finally, endothelium-derived hyperpolarization factors act to promote hyperpolarization of smooth muscle cells in the arterioles, which in the end result being dilation results dilate with the end result being smooth muscle relaxation, dilation of arterioles. Current evidence indicates that interplay between these vasodilatory factors exists, so that elements work together to cause vasodilation of the arterioles, feeding the contracting skeletal muscle. This vasodilation reduces the vascular resistance and therefore increases the blood flow. To summarize, the exercise included increase in local factors result in increased vasodilation of arterioles, small arteries, and promote increased blood flow to the contracting muscle in order to match the metabolic demand. While the vascular resistance to skeletal muscle decreases during exercise, vascular resistance to flow in the visceral organs and other inactivity tissue increases. This occurs due to increased sympathetic output of these organs, which is regulated by the cardiovascular control center. As a result of the increase in basal constriction during exercise, example, resistance increases, blood flow to the viscera can only decrease only to about 20% of the resting values. In summary, oxygen to the skeletal muscle increases due to increased cardiac output and redistribution of blood flow from inactive organs to the contracting skeletal muscles. Cardiac output increases as a linear function of oxygen uptake during exercise. During exercise, in an upright position, stroke volume reaches a plateau of approximately 40 to 60% of VO2 max. Therefore, the work rates above 40 to 60% VO2 max, the rise in cardiac output due to increased. Therefore, at work rates above 40 to 60% VO2 max, the rise of cardiac output is due to increases of heart rate alone. During exercise, blood flow to contracting muscle is increased, and blood flow to less active tissues is reduced. Regulation of muscle blood flow during exercise is regulated by local factors called autoregulation. Autoregulation refers to the intrinsic control of blood flow by increases in local metabolites. Examples: nitric oxide, prostaglandin, ATP, adenosine, and endothelium derived from hyperpolarization factors. These factors work together to promote vasodilation to increase blood flow to working muscles. Circulatory responses to exercise. The changes in heart rate and blood pressure that occur during exercise reflect the type of intensity of exercise performed, the duration of exercise, and the environmental conditions under which the work was performed. For example, heart rate and blood pressure are higher during an arm work when compared to leg work at a given oxygen uptake. Further exercise in a hot, humid condition results in a higher heart rate when compared to the same exercise in a cool environment. The next several sections discuss the cardiovascular responses to exercise during a variety of exercise conditions. Changes in cardiac output, stroke volume, and heart rate during transition from rest to submaximal constant intensity exercise during recovery. See text for discussion. Exercise recovery, heart rate, recovery, stroke volume, cardiac output. Emotional influence. Submaximal exercise is emotionally charged at submaximal exercise in an emotionally charged atmosphere results in a higher work rates and blood pressures when compared to the same work in a physiologically neural environment. This emotional elevation in the heart rate and blood pressure responds to exercise and mediated by an increase in sympathetic nervous system activity. If the exercise is maximal, example 40-meter dash, high motion elevates the pre-exercise heart rate and blood pressure, but does not generally alter the peak heart rate or blood pressure observed during the exercise itself. Transition from rest to exercise. At the beginning of exercise, there is a rapid increase in heart rate, stroke volume, and cardiac output. It has been demonstrated that the heart rate and cardiac output begin to increase within the first second after muscular contraction. It begins. If the work rate is constant and below the lactate threshold, a steady plateau in heart rate, stroke volume, and cardiac output is reached within 2 to 3 minutes. This response is similar to that observed in oxygen uptake at the beginning of exercise. Recovery from exercise. Recovery from short-term low-intensity exercise is generally rapid. This is illustrated in figure 925. Notice that heart rate, stroke volume, and cardiac output all decrease rapidly back toward resting levels following the type of exercise. Recovery speeds varies from individual to individual, with well-conditioned subjects demonstrating better recuperative powers than untrained subjects. In regard to recovery heart rates, the slopes of heart rate decay following exercise generally the same for trained and untrained subjects. However, some trained subjects recover faster following exercise because they don't achieve as high a heart rate as untrained during a particular exercise. Recovery from long-term exercise is much slower than the response depicted in figure 925. This is particularly true when exercise is performed in hot, humid conditions because elevated body temperatures delays the fall in heart rate during recovery from exercise. Incremental exercise. The cardiovascular responses in dynamic incremental exercises were illustrated in figure 922. Heart rate and cardiac output increase in direct proportion to oxygen uptake. Further, blood flow to muscles increases as a function of oxygen uptake. This ensures that a need to synthesize as the need to synthesize ATP to supply the energy for muscular contraction increases, the supply of O2 reaching the muscle also increases. However, both cardiac and the heart rate However, both cardiac output and heart rate reach a plateau at approximately 100% VO2 max. This point represents a small ceiling of oxygen transport to exercising skeletal muscles and is thought to occur simultaneously. However, both cardiac output and heart rate reach a plateau at 100% VO2 max. This point represents a maximal ceiling for oxygen transport. Oxygen transport to exercising skeletal muscles and is thought to occur simultaneously with the attainment of maximal oxygen uptake. An increase in cardiac output during incremental exercise is achieved via a decreased vascular resistance to flow and increase to mean arterial blood pressure. The elevation in mean arterial blood pressure during exercise is due to an increase in systolic pressure because diastolic pressure remains fairly constant during incremental work. As mentioned earlier, an increase in heart rate systolic blood pressure that occurs during exercise results in increased workload on the heart. The increased metabolic demand placed on the heart during exercise can be established by examining a double product. The double product also known as rate pressure product, is computed by multiplying a heart rate times systolic blood pressure. Double product equals heart rate times systolic blood pressure. Table 9.3 contains an illustration of changes in the double product during an incremental exercise test. A heart rate times systolic blood pressure. Note that the double product is a dimensionless term that reflects the relative changes in the workload placed on the heart during exercise and other forms of stress. Changes in the Dal product, example heart rate times systolic blood pressure during an increase intermittent exercise test in a healthy 21-year-old female subject. Rest, exercise. The take-home message in Table 9.3 is simply that increases in exercise intensity results in elevation in both heart rate and systolic blood pressure. Each of these factors increases workload and is placed on the heart. Careful examination of Table 9.3 reveals that the double product, also known as rate pressure, is computed by multiplying the heart rate times systolic blood pressure. As mentioned earlier, the increase in heart rate and systolic blood pressure occurs during exercise, results in increased workload on the heart. The increased metabolic demand placed on the heart during exercise is estimated by examining the double product. Careful examination of Table 9 reveals that the double product during exercise at VO2 max is 5 times greater than the double product at rest. This implies that the maximal increases. This implies that the maximal exercise increases the workload on the heart by 500% over rest. The practical application of the double product is that the measure can be used to guideline to prescribe exercise for treatment with coronary artery blockades. For example, suppose a patient develops a chest pain called angina pectoris at a certain intensity. For example, a patient develops chest pain called angina pectoris at a certain intensity of exercise due to myocardial ischemia at the double product of 3,000. Because the chest pain appears at the double product of 3,000, the cardiologist or exercise physiologist would recommend this patient perform types of exercise that result in a double product of 3,000. This would reduce the risk of the patient developing chest pain due to high metabolic demand of the heart. Arm versus leg exercise. As mentioned earlier, at any given level of oxygen consumption, both heart rate and blood pressure are higher. During arm work when compared to leg work. See figure 926. Comparison of mean arterial blood pressure and heart rate during submaximal rhythmic arm and leg exercise. Blood pressure, heart rate. The explanation for this higher rate seems to be linked to a greater sympathetic outflow to the heart during arm when compared to leg exercise. In addition, isometric exercise also increases the heart rate above the expected value based on the relative oxygen consumption. The relatively large increase in pressure during work is due to the basal constriction in the inactive muscle groups. In contrast, the larger the muscle group, example legs, involved in performing the exercise, the more resistance vessels arterioles that are dilated. Therefore, the lower peripheral resistance is reflected in the lower blood pressure, because cardiac output times resistance equals pressure. Intermittent exercise. If exercise is intermittent, example interval training, The extent of the recovery of the heart rate and the blood pressure between exercise bouts depends on the level of the subject's fitness, environmental conditions, temperature, humidity, and the duration of intensity of the exercise. With a relatively light effort in the control environment, there is a generally complete recovery between the exercise bouts within several minutes. Exercise intense. However, exercise if the if the exercise is intense or the work is performed in a hot, humid environment, there is a cumulative increase in heart rate before efforts, and thus recovery is not complete. The practical consequence of performing repeated bouts of light exercise is that many repetitions can be performed. In contrast, the nature of the high intensity exercise dedicates that a limited number of efforts can be tolerated. Prolonged exercises. Figure 927 illustrates the change in the heart rate, stroke volume, and cardiac output during prolonged exercise at constant work rate. Changes in cardiac output, stroke volume, and heart rate during prolonged exercise at constant intensity. Notice that the cardiac output is maintained by an increase in heart rate to offset all the fall in stroke volume that occurs during this type of work. Note that the cardiac output is maintained at a constant level throughout the duration of the exercise. However, the duration of the exercise increases stroke volume, declines while heart rate increases. Figure 927 demonstrates the ability to maintain a constant cardiac output in the face of declining. Figure 927 demonstrates the ability to maintain constant cardiac output in the face of declining stroke volume is due to an increase in heart rate being equal to the magnitude to the decline in stroke volume. The increase in heart rate and decrease in stroke volume observed during prolonged exercise is often referred to as cardiovascular drift. Increase in heart rate and decline in stroke volume is in prolonged exercise known cardiovascular drift, and due to the influence of the rising body temperature on dehydration and reduction of plasma volume. Reduction of plasma volume acts to reduce venous return to the heart, and therefore reduces stroke volume. If prolonged exercise is performed in a hot, humid environment, the increase in heart rate and decrease in stroke volume is exaggerated even more than depicted in Figure 927. In fact, it is not surprising to find a near maximal heart rates during submaximal exercise in the heat. For example, it has been demonstrated that during a 25-hour marathon race at a work rate of 75% to 75% VO2 max, maximal heart rates may be maintained during the last hour of the race. During prolonged exercise at high heart rates pose a risk of cardiac injury. The answer to this question is almost always no for healthy individuals. However, sudden cardiac deaths have occurred in individuals of all ages during exercises. See clinical applications for more details of sudden cardiac deaths during exercise. In summary, the changes in the heart rate and blood pressure that occur during exercise are a function of the type of intensity and exercise performed in the duration of the exercise and environmental conditions. The increased metabolic demand on the heart during exercise can be estimated by examining the double product. An increase in heart rate occurs during prolonged exercises called cardiovascular drift. Clinical applications: sudden death, cardiac during exercise. Sudden death is defined as an unexpected, natural, and non-violent death occurring within the first 6 hours following the beginning of symptoms. Note that not all sudden deaths are due to cardiac events. In fact, in the United States, only 30% of sudden deaths in people between 14 and 21 years of age are cardiac in origin. However, how many of these cases of sudden deaths occur during exercise? Each year, fewer than 20 cases of sudden death cardiac, fewer than 20 cases of sudden cardiac death during exercise are reported in the United States. Therefore, given the millions of people actively engaged in sports and regular exercise in the United States, the likelihood a healthy person will die from sudden cardiac death is extremely small. Across the world, it's estimated that sudden cardiac death occurs in 1 out of 200,000 youth athletes. Again, the risk of sudden cardiac death in young athletes is limited. The causes of sudden cardiac death are diverse and vary of the function of the age. For example, in children, adolescents, most sudden cardiac deaths occur due to lethal arrhythmic abnormal rhythm. These arrhythms can arise from genetic abnormalities or coronary arteries, cardiomyopathy, wasting cardiac muscle due to its disease, or myocarditis, inflammation of the heart. In adults, coronary heart disease, and cardiomyopathy are the common causes of cardiac sudden deaths. Similar to sudden death in children, sudden cardiac deaths in adults are also generally associated with lethal cardiac arrhythms. Can medical exams identify people at risk for cardiac death during exercise? Yes. The combination of medical history and complete medical exam by a qualified physician can usually identify the individuals with undetected heart disease or genetic defects that would place them at risk for sudden death during exercise. Regulation of cardiovascular adjustments to exercise. The cardiovascular adjustments at the beginning of exercise are rapid. Within 1 second after the commencement of muscular action, there is a withdrawal of cardiovascular adjustments at the beginning of exercise are rapid. Within 1 second after the commencement of muscular contraction, there is a withdrawal of vagal outflow to the heart, which is followed by an increased systematic stimulation of the heart. At the time, there is a vasodilation of the arterioles in the active skeletal muscles, and the relative increase in resistance to the vessels is less active. The result is an increase in cardiac output and ensure the blood flow to the muscles matches the metabolic needs. Figure 928. A summary of cardiovascular responses to exercise. Deeper breathing, skeletal muscle activity, improve venous return, sympathetic adrenal system, cardiac rate up, stroke volume up, cardiac output up, blood flow to skeletal muscles up, metabolic vasodilation in muscles, sympathetic vasoconstriction in the viscera. What is the signal to turn on the cardiovascular system in the onset of exercise? The question has puzzled physiologists for many years. A present complete answer is not available. However, recent advances to understanding cardiovascular control has led to the development of the central command theory. The term central command refers to the motor signal developed within the brain. The central command theory the central command theory of cardiovascular control argues that the initial cardiovascular changes begin being of the dynamic exercise, example, cycle ergometer exercise, are due to the centrally generalized cardiovascular motor signals, which set the general pattern of the cardiovascular response. However, it is clear that the cardiovascular activity is also regulated by the afferent feedback to higher brain centers from the heart, mechanical receptor, muscle chemoreceptors, mechanical receptors, and pressure-sensitive receptors, receptors located within the carotid arteries and the aortic arch. The muscle chemoreceptors are sensitive to changes in muscle metabolites. Example, potassium lactic acid, and sends messages to the higher brain centers to fine-tune the cardiovascular responses to exercise. This type of control is peripheral feedback. This type of peripheral feedback to the cardiovascular control center. This type of peripheral feedback to the cardiovascular control center, medulla oblongata, is located in the exercise. It's called the exercise pressor reflex. Muscle mechanical receptors. Example, muscle spindle, Golgi tendon organs are sensitive to the force and speed of muscular movement. These receptors, like muscle chemoreceptors, send information to the higher brain centers to aid in modification of the cardiovascular responses given exercise tasks. Finally, baroreceptors, which are sensitive to changes in arterial blood pressure, may also send afferent information back to the cardiovascular control center to add precision to the cardio activity during exercise. These pressure receptors are important because they regulate arterial blood pressure around the elevated systemic pressure during exercise. In summary, the central command theory proposes the initial signal to the cardiovascular system at the beginning of exercise comes from the higher brain centers. However, fine-tuning of the cardiovascular response to a given exercise test is accomplished via a series of feedback loops from the muscle chemoreceptors, muscle mechanical receptors, and arterial brachial receptors. Figure 929. Central command centers, cardiovascular control center, baroreceptors, blood vessels, heart, chemoreceptors, mechanical receptors, muscle. A series of cardiovascular control during exercise. See text for information. The fact that there appears to be some overlap among these three systems during submaximal exercise suggests that reductory in cardiovascular control exists. This is not surprising considering the importance of matching blood flow to metabolic needs of exercising skeletal muscle. Whenever one of the many of these feedback loops becomes more important during heavy exercise, it is not currently known and poses an interesting question for the future. In summary, the central command theory, the cardiovascular control center, during exercises proposes that the initial signal to drive the cardiovascular system at the beginning of the exercise comes from the higher brain centers. Although the central command is primary drive to increase the heart rate during exercise, the Cardiovascular response of exercise is fine-tuned by a feedback from muscle receptors, muscle chemoreceptors, muscle mechanical receptors, and arterial baroreceptors in the cardiovascular control center.